All right. Welcome, everyone. Thank you for joining us on this fourth day of World Breastfeeding Week 2021. We are recording this webinar today to hopefully share out to others who may not have been able to join us live. Now would be a great time while we wait for others to join, if they're able, for you to introduce yourself in the chat box. And just say your name, your pronouns, where you are right now, where you are working or where you live, and anything else about yourself that you would like to share. And I'll introduce myself. My name is Erika. I'm a lactation consultant. I'm the board president of the Maine State Breastfeeding Coalition. And I am here in Freeport. And really looking forward to this presentation today to learn more about what's happening in the state of Maine regarding breastfeeding and some statistics that can really help us to understand where to guide us going forward in our work. So like I said, you should all have access to the chat box. So if you could introduce yourself there so we all know where you're from and who you are, that would be great for everyone else in the webinar today, especially the presenters, to know who they're speaking to. So if you could go ahead and please introduce yourself, name, pronouns, town, etc. All right, and I also want to share in the chat box the rest of our World Breastfeeding Week webinars that are coming up. So if you click on that link, that'll bring you right to our website where you can see our flyer and see, I might actually just share that right now while we're waiting. So you can see that we have more webinars this week. You can still sign up going to our website. Our Eventbrite links are right listed there if you click on these here. So with our Maine State Breastfeeding Coalition meeting tomorrow, that's our next webinar. You can register for that through Eventbrite, or if you are on our mailing list, I will be sending our usual Breastfeeding Coalition meeting login info. And the global latch on, if you are a lactating parent, please join. If you aren't, please share with everyone that you know who might be interested in being part of that community event. And then we also have a great webinar by the folks at Jade Integrated Health, who will be speaking about the benefits of physical therapy and acupuncture on breastfeeding. And then the person who runs the website, exclusivepumping.com, Amanda is her name, she will be speaking about exclusive pumping, and that will be really great for anyone who's interested in that topic as well. So for today, I definitely want to thank our sponsor, Pump Spotting. Speaking of Pump Spotting, I see Nina is here and she just introduced herself. So welcome, Nina. Thanks for being here and thanks for being part of our week by sponsoring this event. And I also see that Jessica is here. Dr. Rosenthal, thank you for being here. Great to see you here. So I'm going to go ahead and introduce our speakers. And I will stop sharing my screen first. So first, Erika Lichter is here, and Erika is an associate research professor at the University of Southern Maine's Muskie School for Public Service and has worked as the lead maternal and child health epidemiologist for the state of Maine since 2005. Dr. Lichter has a doctorate in maternal and child health with concentrations in epidemiology and biostatistics. Awesome. Thank you so much for being here. Erika, the information that you work on every day is really, really helpful and really informative in the work that we do. And Megan Baker, pronouns she, her, is a Master of Public Health student participating in the Graduate Student Epidemiology program. She's been working under the Department of Health and Human Services, DHHS, for the Association of Maternal and Child Health program. She's currently working with the Maine Center for Disease Control and Prevention and will be presenting on the state of Maine's Pregnancy Risk Assessment Monitoring System, or PRAMS. That is data that you have probably heard of before. So thank you for being here. Megan and Erika. And I believe, Erika, you are up first, and go ahead and share your screen. Okay, and you're muted right now.
Can everyone hear me and see the slides? Great. Thank you. Thank you all so much for being here and inviting me to participate in this World Breastfeeding Week event. As Kara said, I'm an epidemiologist working on maternal and child health at the Maine CDC. And so I'm very involved in data analysis related to infants and birth outcomes, and that includes breastfeeding. So my role today in this webinar is to just give you a broad overview of what data are available in Maine related to breastfeeding. Some of this may be review for some of you, and if so, I apologize for that. But I'm just going to go through some of the major data sources, and then my colleague Megan is going to really dive into the PRAMS data and give you more information about what we can learn from that data source. I'll advance my slides. Okay, so these are the 4 main data sources that we rely on to examine breastfeeding in Maine. So the first one, a lot of you are probably familiar with, it's actually the National Immunization Survey that includes questions on breastfeeding. And this is where we get a lot of our information on breastfeeding initiation and duration up to 12 months. This is really the only source we have on long-term breastfeeding. However, it's very limited in terms of what data are available at the state level, and we don't get much information from the social context or what's going on in women's lives. And it is a sample of women in the state. So about 15,000 parents participate nationwide, but only a much smaller sample are actually from Maine. The next survey I'm going to briefly touch on is the MPINK survey, which is a survey on hospital practices around breastfeeding, which is completed by hospitals in Maine. One of the benefits is that we do get national comparison data, and they create scores on the MPINK survey to compare Maine hospitals to other hospitals around the nation. Unfortunately, not all hospitals participate, but in 2018, about 81% of hospitals in Maine participated in the MPINK survey. Then I'm going to talk a little bit more about birth certificate data. So I'm not sure if everyone's aware, but there is a checkbox on the birth certificate that indicates whether or not a woman was breastfeeding when they left the hospital. One of the benefits of this is that we then have this data on all births in Maine, not just a sample. And so we're able to pull up county as well as sub-county data and compare and look at breastfeeding in relation to things like birth outcomes or demographics or other factors that you might find on the birth certificate. One of the cons of this data set, of course, is that it's really a point in time. It's just when women are leaving the hospital. So we really don't know what happens when they go home. So we just know were they breastfeeding when they left the hospital. And so again, we don't get women's perspectives on breastfeeding or the context of their lives. And then Megan's really going to talk about the pregnancy risk assessment monitoring system, which is a survey of new moms. And in this survey, we do get breastfeeding initiation. We have limited information on some duration, but we do get more detailed information on women's reasons for starting and stopping breastfeeding, as well as some of the challenges they may face in their lives during pregnancy, as well as after pregnancy that could impact breastfeeding. PRAMS is linked to the birth certificate, so you're also able to do analyses related to any birth outcomes that you might find in the birth certificate, and it does give us a little more context on what's going on in women's lives. But it is also just a sample, a small sample of women that Megan will tell you about. We don't have a lot of long-term follow-up, so the duration of breastfeeding data are limited, and we actually don't have information on exclusivity of breastfeeding. So I'm going to go through each one of these, except I'm going to leave PRAMS for Megan. So the National Immunization Survey, as I mentioned, it's a telephone survey of random households with children and teens. So it really is a survey about immunization, and it started out that way. But then in January 2003, all respondents who had children between the ages of 19 and 35 months were asked the breastfeeding questions. And in 2018, the survey changed to a cell phone only sample. So there is some question on whether we can compare data prior to 2018, to 2018 and beyond, but that's something that they're still working on and trying to figure out. These are the questions that are on the National Immunization Survey. So they ask, was the child ever breastfed or fed breast milk? How old was the child when they completely stopped breastfeeding? How old was the child when they were first fed formula? And also, how old was the child when they were first fed anything other than breast milk or formula? The way the National Immunization Survey data are presented, it's from a birth cohort. So for example, today I'm going to be showing you some data based on infants born in 2017. So what they do is they take the data from those who were sampled in 2018 and 2019, and they look back at the infants who were actually born in 2017, since they're asking moms to look back retrospectively at their breastfeeding at the time of births. So that in 2018 and 2019, they're talking to women who might have gave birth in 2017, because they're talking to women who have kids between 19 and 35 months of age. So just looking at some of the data from this survey, you can see that Maine has made some substantial progress in improving our breastfeeding rates. So you can see between 2009 and 2017, our ever breastfeeding rates increased from 74% to 88%. Our breastfeeding rates at 6 months increased from 42% to 62%. And at 12 months, we increased from 23% to 40%. So there's really been some significant strides over the past 10 or so years. When we compare Maine to the US, we're very comparable to US rates, slightly higher, but not really statistically significantly higher. So in terms of ever breastfeeding, this is among infants born in 2017. You can see about 88% of Maine infants breastfed compared to 84% in the US. And then I put down here just the highest stage. So where are we trying to strive for if we were trying to get to this highest rate? So Minnesota is actually at 95% of women ever breastfed, and Maine ranks about 18th highest on this measure. In terms of breastfeeding at 6 months, again, you can see Maine's at about 62% compared to the US at 58%. Minnesota, again, has the highest rate on this indicator at about 79% are breastfeeding at 6 months, and Maine is 21st highest on this indicator. And then in terms of breastfeeding at 12 months, Maine's at almost 40% compared to 35% in the US. Highest state on this indicator is Hawaii, and they have about 55% of women reporting that they were breastfeeding at 12 months, and Maine ranked 16th highest on this indicator. When we look at exclusive breastfeeding, Maine's doing, again, slightly better than the US. So we're at about 53% or exclusively breastfed at 3 months compared to 47% in the US. Oregon actually had the highest on this measure at about 66% exclusively breastfeeding at 3 months. And Maine ranked 13th highest on this measure. And then for 6 months, Maine was at 28% compared to the US at 25%. Minnesota again had the highest at about 38%, 39%, and Maine ranked 18th highest. We are actually, in terms of New England, Northern New England does better on all of these indicators compared to some more Southern New England, but Vermont tends to score the highest, and then Maine and New Hampshire are pretty similar. So that was just some data from the National Immunization Survey. Then moving on to the MPINC survey. This is, again, I just pulled some of the responses. There's a lot more, and I have in the next slide, I'll have the link so you can actually go if you want to look at the report. They put out an actual report from the MPINC survey. I just wanted to highlight a few things where Maine is doing really well. You can see that in terms of mother-infant dyads not separated before rooming in if there was a vaginal delivery. In terms of the hospitals that have the ideal response on this, 100% of the Maine hospitals who filled out this survey said that they do not separate mother-infant dyads. In terms of few breastfed infants receiving formula, Maine 86% of the hospitals had an ideal response to that. And in terms of breastfeeding mothers are taught how to recognize and respond to feeding cues, breastfeed on demand, and understand the risks of artificial nipples and pacifiers. About 95% of hospitals reported doing this. Oops. Maine's not doing quite as well on some of the others in terms of mother-infant dyad rooming in 24 hours a day. That's about 67%. And in terms of breastfeeding mothers shown how to position and latch their newborn and assess effective breastfeeding and hand expressed milk, we're at 76%. And similarly with giving gifts such as infant formula, bottles, nipples, nipple shields, pacifiers, and coupons, that's also at about 76%. But if you're interested in looking more at these results, I have the link on my slides down here, and you can go and have the whole MPINC report where they show all of the different items that are collected with the scores that the state got compared to national. So they have those scores for each of these subgroups that they have on the survey. So there's a lot more detailed information that I'm not going to go into today, but here's the link for anyone who's interested in it. And I believe they do this every other year. So 2018 is the most recent one, but they just wrapped up the 2020 MPINC survey. So the last data set I'm going to talk about is the birth certificate. So for those who, I know some of you may be familiar with filling this out, but here is the item. I don't know if you can read it. Sorry, it's really tiny. It's just a checkbox. Is the infant being breastfed at discharge? And who's ever filling out the birth certificate. So this is on the medical worksheet. So this is not the part that the mom fills out. This is the part that the provider fills out. And so the provider would indicate yes, no, or unknown for breastfeeding at discharge.
Erika,
So,
can I ask a question?
Yeah, sure.
Has that changed at all, those questions? The yes, no, or unknown? Was there a question about both? Or if they're receiving both breast milk and formula? Or is that a different, I feel like I've seen a report that it's the newborn feeding report where it shows breast milk, formula, or both.
I have not seen that. This is the most recent worksheet that I have seen. This question was also just added to the birth certificate in 2014, or well, partway through 2013 when Maine switched to the new birth certificate. So this is from the national, this is the US standard birth certificate item. So I haven't seen that other.
I'll send you the report that I've seen and maybe it's something different.
Okay, yeah, no, please, I'd love to see that. So in terms of breastfeeding at hospital discharge, we also have been increasing. We are increasing fairly rapidly and consistently between 2014 and 2018. Things did decrease in 2019 and again in 2020. I looked at the first half of 2021, so this is data through mid-July, and we're at about 88% right now. So we'll have to see if that continues at that for the next half of a year. And so I'm not sure if this has anything to do with COVID or what's going on, but we'll continue to monitor this on an ongoing basis. For US data, it's only available between 2016 and 2019 right now. And you could see the US has stayed pretty consistent over that period of time, where Maine had a much steeper increase, but then unfortunately has decreased in recent years. So if anyone has any insight into that, I would definitely be interested in hearing your perspective. We do see, sorry, my dog's barking out there. You can see that breastfeeding does vary by county. So some counties have higher rates at hospital discharge. So you could see it's about half of Maine counties are at 90% or higher in terms of breastfeeding at hospital discharge. And then the other half are much lower in terms of breastfeeding rates. And you could see some of Maine's more rural counties like Aroostook and Washington and Somerset have some of the lower rates of breastfeeding at hospital discharge. We have created some maps related to this that I can share with Kara to disseminate. So we have this breastfeeding at hospital discharge map that just shows, you can see that the rates, so the darker is actually lower rates of breastfeeding. So you can see in the northern part of the state, there do tend to be lower rates of breastfeeding at discharge compared to the more southern counties. We've also created maps. This is for many different birth outcomes at the town level, and we have these for each county. So we looked at breastfeeding within each county at the different towns, and we created these. It was primarily actually for our home visiting needs assessment, so our home visitors could see where in their catchment areas they were doing, they might want to reach out and do further intervention. But we are able to share these maps if anyone is interested. So some of the other data analyses that we did on the birth certificate data. So women, and this is similar to what we saw on the map. So women living in more urban areas are more likely to be breastfeeding at discharge compared to those that live in more rural areas. And the likelihood of breastfeeding at hospital discharge increases with age, which I think you'll also see echoed in Megan's analyses of PRAMS. So you can see among the youngest women, they are less likely to breastfeed compared to women who are older. Educational attainment is also associated with greater likelihood of breastfeeding. So, and there's a pretty linear relationship. So about 74% of those with less than a high school diploma are breastfeeding at discharge compared to about 96% of those with a college degree or more. When we look at race, we see that women who are Asian and African American are actually more likely to be breastfeeding at hospital discharge compared to other races. There was no difference between Hispanic and non-Hispanic women in terms of breastfeeding at discharge. And women whose delivery was paid for by Maine Care were less likely than those who are insured by other insurers to breastfeed at discharge. You can see it's about 80% for those insured by Maine Care compared to over 90% with other insurers. There's a lot of other potential analyses that can be done with the birth certificate that we haven't delved into yet, but as I mentioned, we can look at birth outcomes, prenatal care, things like maternal morbidity, and how those impact breastfeeding. And Megan's going to talk about some of those, but we can also use the birth certificate as well. So I'm going to turn it over to Megan for her presentation. One of the things I just wanted to say before she goes is you'll see some of the results from the PRAMS analyses are consistent with what I've shown you, and others differ a little bit. And some of that has to do with the fact that PRAMS is a sample of women. It's not all. The data are collected differently, so women themselves are filling out a birth certificate. So maybe a woman was breastfeeding when she left the hospital, but then got home and stopped right away. So she might not consider herself to ever be breastfeeding. So we have to remember that. And just the timing also. So the birth certificate, again, is filled out right at the hospital versus women are filling out the PRAMS survey 3 months after they give birth. However, the PRAMS does provide us with a lot more context from women on what's going on, as I mentioned previously. So that's the end of my presentation. So I don't know if people have questions before we move on to Megan's.
Thank you, Erika. That was really excellent. And did you say you'll send the slides to me as well so we can have that available? That's so helpful to have.
Yep, sure, I'll send them.
Yeah, and any questions, this does go until 2:30. So if you have any questions, you can save them to ask both Erika and Megan after Megan speaks, or you're welcome to chat them in the chat box at any point too. And I can ask those at the end. All right, thanks, Erika.
There we go. Sorry. I clicked share screen and then I couldn't find the unmute button. So good afternoon, everyone. My name is Megan Baker, and I am currently participating in the graduate student epidemiology program and working under the Department of Health and Human Services for the Association of Maternal and Child Health program. For the past 9 weeks or so, I have been working closely with the Maine Center for Disease Control and Prevention. And today I will be presenting on the breastfeeding data provided by the Pregnancy Risk Assessment Monitoring System Survey, or PRAMS, as you will see from here on out. and that will pertain to the data collected between 2016 and 2019. If you have any questions during the presentation, please feel free to pop them in the chat box and I will try to respond to them as quickly as possible. And then if you're hearing any background noise, I apologize. My neighbors are being very loud today, so I am sorry about that. There we go. All right. So as an introduction to the nationwide PRAMS survey, the following two slides provide a brief overview for the design and functionality of the PRAMS survey. The PRAMS survey collects state-specific population-based data on maternal attitudes and experiences before, during, and after pregnancy. The PRAMS survey has utilized the same questions for all of phase 8 for the years 2016 to 2020. And the phase 1 survey actually began in 1988, and each subsequent phase, so phases 2 through 8, have all gone on for about 4 to 5 years. And the results presented in the report include both the core questions, which are required of all states and participating territories to include in the survey, as well as the standard questions, which states and territories have the option to include in the survey. So there is a little bit of differentiation as far as the standard questions go. However, the core questions are required to be in every version of the PRAMS survey. The phase 8 survey can be found on the CDC website, as well as all participating state and territory websites. Currently, there are 46 states participating and 2 United States territories participating in the PRAMS survey. And you can see a nice example of the state of Maine PRAMS survey on the corner of my slide right here. That is taken from the Maine PRAMS website. And again, they are all visible on the CDC website for PRAMS. So as a little bit mentioned earlier, the PRAMS survey is mailed to approximately 125 women each month and is typically dispersed around 3 months after the birth, which is why we are going by the variables of ever breastfed and breastfed for 8 weeks or longer, because that is typically when women do receive the survey. And then from 2016 to 2019, Maine's population increased from about 1.3 million to about 1.35 million, while births did decrease from about 12,698 to about 11,770. The CDC listed an ideal response rate of about 60%, which Maine has been typically close to and has stayed fairly close to ever since it joined the PRAMS survey. And another goal of the PRAMS survey is to accurately sample the women who gave birth in a given year. And this leads us into our first question: is the Maine PRAMS data an accurate representation of all women who have given birth in the state of Maine in that particular year? So firstly, we are looking at the PRAMS data. As a note, the PRAMS data has been weighted to be a little bit more representative of all births in Maine, so that has been taken into account. However, it is still not as accurate of a representation as the birth data, as Erika mentioned earlier, because this is a sample. Out of those, 12,000 each year, we only had about 817 responses. Therefore, it is not going to be a perfect representation. All right. And as far as the years of education and age go, years of education did differ from all birth certificate data by about 4 to 7%. According to all birth certificate data, about 24% of the women who gave birth from 2014 to 2020 had about 12 years of education, and 30% had a college degree or higher, so that would be greater than 16 years. And the distribution was about what you could expect as far as age goes, as it very closely aligned with all of the birth certificate data, which accounted for all births, as that data reported that mothers under the age of 20 made up about 4% of all births, and women ages 25 to 34 made up about 60.1% of all births, which you can see is very close to what the PRAMS survey received. All right, and then moving on to marital status and insurance. Marital status and postpartum insurance status were also well represented, with about a standard error of about 1%, meaning that there was a difference of about plus or minus 1% for all of the variables seen on the screen, which again is fairly fantastic. I think living or living as married was about 61%, and other was about 38%. So it was very close and not found to be a statistically significant difference between the two, indicating that it was a fairly good representation of all women within that marital status and postpartum insurance status. As far as race and ethnicity go, these were pretty well represented, as there was a standard error of about 2% at the most. According to all birth certificate data, about 91.2% of all births from 2014 to 2020 were white and 4% were Black or African American. Additionally, 97.9% of all births were non-Hispanic, again indicating that PRAMS was fairly representative of the overall women who did deliver within the years 2016 to 2019. Household income was the demographic factor found to be least representative, as women who had a household income of greater than $57,000 were more likely to respond to the PRAMS survey, and women with a household income of less than $20,000 were less likely to respond to the PRAMS survey. The overall distribution of births in the state of Maine saw fewer women with a household income of greater than $57,000. This is the only demographic variable that was a little bit less representative, but in the analyses, we did account for that particular weighting in order to decrease the statistical errors, which could be present from having an unrepresentative group of data. All right, now moving on to our second question. How does the state of Maine compare to all participating PRAMS locations? I believe Erika did mention this a little bit earlier, but overall, the state of Maine was seen to be a little bit higher for ever breastfeeding and breastfeeding for greater than 8 weeks. And that is fairly clear. For Maine, the cumulative percent for ever breastfed was about 91%, and for greater than 8 weeks, it was about 72%, which does rank above the overall United States PRAMS participant rates. All right, and third question, what demographic characteristics are related to breastfeeding, initiation, and breastfeeding for at least 8 weeks postpartum? So first, when examining all of the aforementioned demographic factors, it was found that there was no statistical significance seen between race and ethnicity for breastfeeding ever and breastfeeding for 8 weeks or longer. The variable Native American or Alaskan Native had to be excluded from this graph because there were too few participants to be included in the analysis, and the remaining analyses do tend to revolve around all of the other demographic variables already mentioned, as they were more influential. This is one of those moments where using all birth certificate data might be a little bit more representative, just because you are capturing all 12,000 women that gave birth within a particular year versus the 800 or so that PRAMS tends to receive within 1 year. And that is unfortunately why race and ethnicity were not able to be thought of as much during the PRAMS analysis, just because the numbers were not high enough to be statistically significant. And then for years of education and age group, we are able to see fairly consistently with what Erika did just present that years of education was found to be very influential, and age group was also found to be influential, however, not at as large of a rate as years of education for ever breastfed. And the same trend is also seen when you consider greater than 8 weeks of breastfeeding. The trend is again very similar, very distinctive for years of education. And for age group, when you factor in greater than 8 weeks or more of breastfeeding, the trend does get a little bit more intense than if you were comparing only ever breastfed. Income was also seen to be fairly influential as well, as you can tell, for both ever breastfed and breastfeeding for 8 weeks or longer. It was a very intense line, especially when comparing under $20,000 per year for household income and greater than $57,000 for household income. That is a difference of about 17%, which is fairly significant. And then when looking at postpartum insurance and marital status, the difference is also fairly significant when looking at Medicaid or Maine care and comparing that to no insurance and private insurance. And it is also fairly significant for other versus married or living as married. The difference is again fairly large, larger than you would anticipate. And when greater than 8 weeks is included, that trend stays fairly similar. We can see that Medicaid or Maine care does tend to drop a little bit more as far as continuing to breastfeed at 8 weeks. And that is something we will go into in the following slides. Just emphasize that a little bit more right there. This was a fairly interesting find and something that we would recommend further research be conducted on, given that Medicaid or Maine care, there are just a large number of factors that could be potentially affecting this finding, given that there are a lot of extenuating factors that would pertain and maybe affect women's decisions to breastfeed and continue breastfeeding. And that is why we would recommend significantly more research and why we will go over that in the following slides. All right, moving on to the fourth question. What are the reasons to choose to not breastfeed or stop breastfeeding? All right, so starting off with reasons women did not breastfeed, among who on the PRAMS survey that they have never breastfed. The most significant variable was I did not want to, at a surprising 39.7%. There were about 300 or so women out of the entire PRAMS 3,332 participants who marked that they had never breastfed. So that is out of these 300 women. And out of the 600, or sorry, about 1,000 women who stopped breastfeeding, 604 of them marked that they thought that they were not producing enough milk as one of the reasons that they had stopped breastfeeding. It is important to note that the two questions just presented were a check all box, so it is not a sole reason. Women were able to mark more than one reasoning behind why they chose to stop breastfeeding and why they chose to never breastfeed. The three variables that were by far the most significant in this group were my baby had difficulty latching or nursing, breast milk alone did not satisfy my baby, and again, I thought I was not producing enough milk. I did go a little bit further into I thought I was not producing enough milk, as that was a very large percentage of why women chose to stop breastfeeding. And this pertains to anyone who marked that they had ever breastfed. And by the time the survey reached their door, they had stopped. We are not necessarily able to tell if they'd stopped after the first day, first week, or at those 8 weeks, right when they received the survey. So take everything with a grain of salt because we aren't able to tell specifically when these women chose to stop breastfeeding. So examining low supply cessations, that would be the 55.7% of women that reported stopping breastfeeding because they felt that they were not producing enough milk or that their milk had dried up. I wanted to examine those 604 women a little bit closer just to figure out if there were any large variables that maybe were influencing this factor a lot more. So I examined age, education, as the first two ones. So age was found to be a significant factor as women under the age of 20 were the most likely to stop breastfeeding for this reason. And as years of education increased, the reasoning behind stopping breastfeeding for low supply actually decreased, which was kind of what you would expect as education increases, stopping due to low supply decrease. Sorry, I wanted to state that again. The sentence is a little bit difficult. There was also a significant increase in cessation for those with a BMI of greater than 30. And there was a positive correlation that smoked cigarettes, indicating that women who smoked cigarettes postpartum were more likely to mark that they had a low supply as their reasoning for stopping breastfeeding. I also examined marijuana use, and there was no significant association for marijuana use and stopping breastfeeding due to a low supply. So when examining reasons for not breastfeeding by income, there were a lot of variables. Again, I didn't want to was found to be the most statistically significant, as well as I didn't like breastfeeding. And I highlighted those right here. Clearly, women who were making greater than 57,000 chose I didn't like breastfeeding more than women who were earning less than 20,000. And I didn't want to was also significantly higher among women who had a household income of greater than 57,000. And that was a relatively interesting find just to see how household income affected women's decisions to stop breastfeeding or for not breastfeeding. And then when examining income and stopping breastfeeding, the trend was also fairly significant in a much larger number of the variables, which are highlighted here. So for I thought I was not producing enough milk or my milk had dried up, it was more significant against women who were earning less than 57,000. The number increased from 52% to 58% in going from earning more than 57,000 a year to earning less than 57,000 a year, indicating that when it does come to income, it does look like having a lower income does increase women's perception of thinking that they were not producing enough milk or that their milk dried up, and therefore leading them to cease breastfeeding. Breast milk alone did not satisfy my baby, and my baby had difficulty latching or nursing, were again found to be statistically significant. And you can kind of see the gradient of going from 57,000 down to earning less than 20,000 a year. The numbers again decreased by about 8%, which was statistically significant, as well as for my baby had difficulty latching or nursing. Again, it did decrease as income decreased as well. And then same before I went back to work or school, it does look like women who were earning greater than 57,000 a year were more likely to stop breastfeeding because they were returning to work or school than women who were earning less than 20,000 a year. And I thought I had too many other household duties also had a very interesting trend in that it went in more of a bell-shaped curve. And it seems like women who were earning between 20,000 and 57,000 were more likely to cease breastfeeding because they had too many other household duties, which I thought was very interesting. Let me change slides. Sorry, I just saw I had a chat. Also interesting, thank you. All right, and then moving on to our next question, do hospital and maternity care practices influence breastfeeding? So comparing women who delivered in a hospital to women who delivered in any facility besides a hospital, you will see that women who delivered in a facility other than a hospital were more likely to ever breastfeed, as well as continue breastfeeding longer than 8 weeks, which I thought was very interesting. And when comparing a baby-friendly hospital to any other hospital facility within the state of Maine, there was no statistical difference when it came to ever breastfeeding and breastfeeding for greater than 8 weeks, as you can clearly see. There are 4 baby-friendly hospitals in the state of Maine, and I don't know everyone's knowledge of the baby-friendly hospitals, but they sign up for it and they are under a little bit more of a strict ruling on what they should be doing after a woman delivers in order to promote breastfeeding. So the lack of a statistical difference between a baby-friendly hospital and all their hospitals was surprising to me. And then again, I do want to emphasize how interesting it was that women who delivered at any other hospital or any other facility other than a hospital were just significantly more likely to continue breastfeeding longer than 8 weeks. And if given the time, I think it would be really interesting to examine maybe a little bit more of why that is, given that normally only 71% or 72% for the entire state of Maine are continuing to breastfeed at 8 weeks or longer. And this is 95.7, which is huge, such a large difference. So that would be a very fascinating thing to look into in the future. All right, and then when comparing maternity care practices supportive of breastfeeding in hospitals, comparing baby-friendly to another hospital and then to overall, there were some statistically significant findings. All of the variables listed on this slide are things that baby-friendly hospitals should be doing. They are kind of included in the contract when signing up to be a baby-friendly hospital and agreeing to be a baby-friendly hospital. So it was fascinating that baby-friendly hospitals only 74% of the women who delivered at a baby-friendly hospital reported that the hospital gave them a telephone number to call for help in pertaining to breastfeeding, while all other hospitals reported that 84% of the women who delivered there received a telephone number to help with breastfeeding. And they did significantly better when it came to breastfeeding within the first hour after their baby was born at 87.4%, while all other hospitals were typically around 82% of women. 82% of the women who delivered in all hospitals in the state of Maine were breastfeeding within the first hour after their child was born. So baby-friendly hospitals did really, really well in ensuring that women were for certain breastfeeding within that first hour, which is fantastic. Don't know why, but every once in a while it won't let me change slides. Okay, so for the maternity care practices unsupportive of breastfeeding in hospitals, this is kind of where baby-friendly hospitals did fantastic. They were about average with giving new mothers a gift pack with formula in it. Everyone was pretty much around 22.5 or 22.6%, so there was no statistical significance there. And for giving mothers a pacifier while in the hospital, baby-friendly hospitals did fantastic, given that that is a maternity care practice that is considered unsupportive of breastfeeding. So they were doing really well in comparison to all other hospitals in that area. All right, and moving on to what other factors in women's lives influence their breastfeeding decisions, which is kind of one of our last questions. So first, we are examining WIC status. So 29.5% of the mothers participated in WIC during pregnancy, and that is out of all of the PRAMS respondents, not any woman who gave birth in the state of Maine. That is just out of our 3,000 or so PRAMS participants. And in 2016, the participation peaked at about 31.6%, which is not a major difference, just about 1.1%. But it is something of note. And then out of the mothers who answered no to why wasn't your baby enrolled in WIC, 10.6% responded that they were not sure what WIC is. Does not greatly pertain to breastfeeding, more of just a generally interesting fact that you can find out with the PRAMS data. And I think that it kind of does a little bit pertain to the general knowledge of, you know, why women are not joining WIC if they are eligible to do so. So in looking at any WIC use, we kind of are able to see that when comparing no WIC services or WIC services for only the mother, it does look like use of WIC for the baby or the mother and the baby, it does seem like breastfed ever is a little bit lower, and the same can be said for greater than 8 weeks. This is something we are also highlighting because that is a fairly interesting find, and it is something that we would recommend further research be done onto, because there are, again, many extenuating factors that are probably influencing this. So adjusting for those extenuating factors like stress, home life, income, I'm sure if those are adjusted for, the numbers will most likely greatly differ. But this would be something to look further into, given that I'm sure that there are a lot of other factors affecting women's response rates to only baby and WIC for mother and baby.
Megan, can I ask a question about this slide?
Sorry, I had to finish my sentence first. Yeah.
Thank you. And Catherine, I see that you are here, and anyone who's watching the recording who works for WIC, I'm sure this is like, you're pulling your hair out when you see that 10% said they're not sure what WIC is. But the question I have is about the no WIC services at the bottom. Are those just the mothers who qualified for WIC but didn't use WIC services, or is that for all of the respondents to the survey who didn't use, they were eligible or not eligible?
This would be kind of where further research would be recommended. On the slide, or on the slide, but on the survey for PRAMS, it's a check all box. So women are able to mark no WIC services, only mother, only baby, and then WIC for mother and baby. So this would be out of women who just stated that they were not receiving WIC services, but it does not enable them to select whether or not they were eligible and chose to not participate in WIC, or if they knew that they were not eligible and chose to not participate and were unable to participate in WIC. We aren't necessarily able to tell. It's just out of women who selected no to the question for WIC.
Okay. All right. Thank you.
Yeah. And this is where the birth certificate data would kind of be helpful, because it's them filling it out. So you would know for certain, because it's not the individual answering the question. Yes, so that would be one of our areas for recommended further research. And I do state that again at the end, just because so many questions pertaining to this slide, but unable to answer based off of the survey questions that are available, unfortunately. Yeah, I'm sure that this is something that we would all want to look further into. All right, and then switching over to food security, birth weight, and breastfeeding. These pertain to the two questions which ask women if in the past 12 months, if they had to use an emergency food source, so food bank, church, anywhere that they could get a free meal, and then could not afford to eat. So that question is just asking if in the last 12 months, women could ever not afford to eat a healthy or sustainable meal. And when looking at food insecurity, it is statistically significant. You can especially see in the difference between continuing to breastfeed at 8 weeks or longer, that women who have experienced food insecurity are less likely to start breastfeeding and less likely to continue breastfeeding for greater than 8 weeks. The difference there is, again, about 15%, which is very large in comparison to women who have experienced food insecurity and women who have never reported never experiencing food insecurity. And then I have nice little charts, arrows to kind of emphasize how great that difference is. And then when looking at birth weight, you can also tell that infants who were born at greater than 2,500 grams in comparison to infants that were born under 2,500 grams, there was a statistical difference in mothers choosing to ever breastfeed, and especially at choosing to continue to breastfeed at greater than 8 weeks. This would also be an area of further interest, just because you would want to examine infants that were born prematurely, or maybe comparing to mothers and their BMI and their health status, just because the difference was fairly significant, again, especially as it pertains to continuing to breastfeed at greater than 8 weeks. Another difference of about 10 or so percent is statistically significant and something that we would want to look into further, just to figure out why that is. And then again, my nice arrow here identifying that as birth weight increases, so does the mother's decision to ever breastfeed and breastfeed for greater than 8 weeks. All right, and then when moving on to co-sleeping and breastfeeding, out of all PRAMS respondents, about 88.5% stated that they most often lay their baby down to sleep on their back, and 61.7% reported that their infant has always slept alone, and 8.4% of the respondents indicated that their infant never sleeps alone. So when looking at these charts, it's kind of a little bit more difficult to follow. So I did color the ones that were found to be statistically significant in comparing infants that always sleep alone and infants that rarely or never sleep alone. You can see that there's a difference of about 7% for ever breastfeeding, at 87.7% for always sleeps alone, and about 94.4% of rarely sleeping alone for ever breastfeeding. And then that difference is even more significant for breastfeeding at greater than 8 weeks, because the difference now is about 85.3% for continuing to breastfeed at greater than 8 weeks for rarely and never sleeps alone. And then when looking at always sleeps alone, it's now at 67.2%, which is a very significant drop, especially considering on average, everyone in the state of Maine is continuing to breastfeed at about 72% while at 8 weeks. So that number is about 5% difference from what you would expect from everyone in the state of Maine. And then when looking at domestic and intimate partner violence, it is important to note first that out of all of the PRAMS respondents, 3% reported experiencing intimate partner violence in the 12 months before getting pregnant, and about 1.99% or 2% experienced intimate partner violence during pregnancy. And these differences were also very significant in that women who experienced IPV both before and during pregnancy were less likely to start breastfeeding and a lot less likely to continue breastfeeding at greater than 8 weeks. With the questions asked on the PRAMS survey, we were unable to get a little bit more information on the factors that might be influencing women's decisions to stop breastfeeding after they have started, if they had experienced IPV in the past. But this would be an area that we would recommend further research be done into, given that the percent decrease is very large. And again, we're at 57 to 55% of women continuing to breastfeed at 8 weeks or longer if they had experienced IPV in the past. And we would hope that they would be around 72%. So that is a fairly significant difference in what the rest of the state of Maine has been experiencing. All right, and then stressful life events. It also got fairly interesting as well. Oh, 5-minute warning, I'll go quick. I'm almost there, sorry. So stressful life events were defined as a sick family member, separation or divorce, moving, homelessness, job loss, anything that would be considered a stressful life event. So anything that might affect a woman's mental status while they are pregnant. This also found a significant trend of, as stressful life events increased, so did the likelihood that a woman will start breastfeeding as well as continue breastfeeding did decrease. As you can see, women with no stressful life events were above average on continuing to breastfeed at 8 weeks as well as ever breastfeeding. And women who were experiencing more than 3 stressful life events in the year before delivering were a lot less likely to start breastfeeding and also continue to breastfeed at greater than 8 weeks. Again, the average we would expect is about 72%. And we are at 65% for women who have experienced greater than 3 stressful life events in the year before delivering. Review and recommendations. So the PRAMS respondents reported ever breastfeeding at a nice 90%, which was fantastic. And 72.2% reported that they were still breastfeeding at 8 weeks or greater than 8 weeks. And among mothers who stopped breastfeeding, it is important to note that 55.7% reported that they had stopped because they thought that they were not producing enough milk or that it had dried up. Continuation at greater than 8 weeks decreased greatly among infants born under 2,500 grams, within families experiencing food insecurity, and also women experiencing life events and IPV. So those would be the groups of women and families that we would want to pay special attention to if you are meeting with them post-delivery and within that first 8-week range, just to see a little bit more of why they are choosing to stop or hopefully preventing stopping breastfeeding at that time if it is not right for them. Well, we would recommend further research, resources, and outreach be directed towards Medicaid participants just to see why they are choosing to stop breastfeeding. Women under the age of 20 years old will likely need a little bit more support in that area, given that they are the most likely to stop breastfeeding. People with 12 or fewer years of education, which kind of goes hand in hand with age, as well as women and infants enrolled in WIC is another area that we would very much recommend further research be conducted in, just because the results were surprising. And I'm sure that there are a lot of other extenuating factors that might be affecting that decision. I finished. Sorry, I had to go really quick those last few slides.
Thank you so much, Megan. That was like better than I could have ever asked for. This data is so good to have. And the Maine State Breastfeeding Coalition has been working on a strategic plan, and we have it just about finalized, but this data might actually help us to make some edits a bit if we decide to go in that direction, because this is the data that really is necessary to inform us on what we should be working on. So thank you so much. Does anyone have any questions or comments? I see Amy Van Haren, who we can see her face. Hi, Amy, saying really informative. Thank you. Other thoughts or questions for Erika or Megan? And I think you both will email me the PDF of the presentation so we can have that. And I think, Megan, are you putting together a report as well that we can have? Or
yes,
before you end? Okay.
Yeah.
We're gonna have a bunch of tables, Kara, and stuff. I'm not sure Megan will have time to put together a full report before she's done, but we'll definitely have all of her analyses, and so we can definitely share that.
That is excellent. Thank you so much. And good luck, Megan, with your future pursuits. And we appreciate this so much. I can't wait to share it with folks who weren't able to make it live today. And thank you again, Pump Spotting, for sponsoring this. Appreciate it. Thank you. Have a great day, everyone.